So, this is your final exam review. Okay, there's some questions on here. Um, you guys can raise your hands if you know the answers. Please don't blurt out because that takes away from the class. But if you know the answers, raise your hand. We're all friends here, right? Somewhat. Or if you don't want to answer, I'll wait like a few seconds and we'll talk about the answer choice, okay? All right, so first question. 35-year-old male, eye pain, marked photophobia, blurred vision. He has a red eye and meiosis. What do you think's going on here? Anyone know? A? Yeah, go ahead. Was it? A? Okay, let's see. Perfect. 10 points. And a free coupon to Chuck E. Cheese. All right, so this is typically confronts with your eye pain, photophobia, red eye. Anything you see red eye, obviously it's in front of you, so it's going to be an anterior part of your eye. So anterior uveitis. Perfect. Good job. All right, next one. So this guy has ankylosing spondylitis, which is an autoimmune disease, and eye pain and photophobia. Which part of the eye is likely inflamed? Anyone want to take a shot at it? You miss 100% of the shots you don't take. Anyone want to take a shot? A? Okay, let's see. All right. So, yeah, you took a shot. That's okay. All right, so iris and ciliary body are structural components in your eye. So, some of these autoimmune diseases do have an effect on the structural proteins of certain parts of your eye. So, that's a good association with that, okay?
How do we know? How do we know that it's what part of the vignette would tell us that?
You associate. I know I put in the notes autoimmune diseases. I put ankylosing spondylosis as one of the examples, and it's associated in that section for that. Yeah, yeah. So that's how it's just going back and studying. Okay. All right. So this next one here. Which of the following is not a common symptom of acute anterior uveitis? You want to take a shot? C? Floaters?
Yes.
All right. Correct. Yeah. So, it's the vitreous body that the floaters are produced in. So, little pieces of the vitreous gel-like substance are breaking off and getting your field of vision. So, good work there. Okay. So, next one. So, this patient presents with blurred vision and floaters, but no eye pain. Remember? I told you guys that. Or foot. Which type of uveitis is most likely? Yeah, the first few are uveitis.
Is this like?
You'll probably see one of these again on the
This
test.
better be a question on the test.
D? All right. Let's see. No eye pain, photophobia, intermediate. Yeah. So you remember that schematic I had with the 4 eyeballs and the different types of uveitis? So that's where you're going to look for that one, okay? All right. Which conditions characterized by leukocytic exudate in the anterior chamber? So raise your hand. Say, Miss Slim, you have a chain. Hypopion. Okay, let's see. Correct. Yes. Strong work. Awesome. Yeah, we went over that yesterday. Remember the picture? Pretty disturbing image there. But yeah. All right. 50-year-old patient. Oh boy, something's going to happen. History of inflammatory bowel disease, eye pain, photophobia. You want to take a shot? Chronic? Okay. Let's see. All right. Someone said B, chronic. Let's see what's happening. Oh, almost. So go back and review some of the examples of diseases I gave in the medical history that are associated with these eye conditions. Okay. Oh, good job. All right. Which is the following is a complication of anterior uveitis? Work through the choices. Know your anatomy. See what's happening. What's the term for the adhesions that can happen? You want to take a shot? D? Okay, let's see. Yeah, so synechiae, that's when the iris adheres to the cornea or the lens and bad things happen, okay? All right. All right, so this patient is seeing you for sudden monocular vision loss. Cherry red spot near the macula. What is most likely diagnosis? A? Okay. Not D? Good work. All right. So that was good. You associated cherry red spot with the disorder. So it's kind of like what you got to do. Okay. All right. So which diagnostic study is essential for a patient suspected of having central retinal artery occlusion with giant cell arteritis? Yes. B? Okay, let's do it. Perfect. Yes. Paid attention in class yesterday. Awesome. She's undefeated. All right. All right. So ESR is for inflammation. Genital arteritis is that big artery right here. You've seen in elderly people that get it. So that's an association with this condition. So patient diabetes. Ding, ding, ding. Sudden monocular vision loss. Blood and thunder retina. What is most likely diagnosis? Which one? B? B as in Bravo? Okay. Bravo, yes, central. All right, so how many of y'all got that one right? Everyone got it right? Awesome. You guys are so awesome. All right, so I don't have enough points to give out for that one, but good work. Okay, which one is not a risk factor for central retinal vein occlusion? Think about what's happening in the pathophys. What could be affecting it? Yes, Jimmy. D? All right, let's take a look. D? Correct. Look at that. Jimmy with 10 points there. All right. Awesome. So know your risk factors, okay? Know your risk factors that make that one of your columns in your little chart, and you'll be able to associate that with the disorder. Okay, so sudden loss of vision in floaters. Which condition should be considered? See? Why is that? Vitreous. Perfect. Yes, vitreous hemorrhage. Awesome. See, if you know your anatomy, you can figure stuff out. See? All right, so which of the following is a common cause of amaurosis fugax? What is amaurosis fugax? Anyone know what it is? Yeah, temporary sudden vision loss. Perfect. From some sort of condition that could arise. So A. Okay. And we're back. A. Yes, emboli. So sometimes this happens if someone's eating a high-fat meal and they're sitting across from somebody and then, oh yeah, I lost my vision. So something could just break off. Yeah, ischemic. So 6-year-old child. There you go. We got pediatric patient. A. Why is that? We just went over this. All right, amblyopia. Yes, perfect. So visual acuity. Perfect. Which is a risk factor for amblyopia? A. Oh, you're so smart. Yeah, good. It helps that we just discussed this. There's there's no questions on uveitis on the fan. Just joking.
I was about to say.
A patient presents with elevated IOP, progressive loss of visual field. A. Chronic open angle glaucoma. Correct. Which of the following is not a symptom of acute closed angle glaucoma? Oh. D. Floaters. Final answer? Yes, you got it. Yeah. So acute closed angle glaucoma. Keywords here: steamy cornea, fixed mid-dilated pupil, severe eye pain, halos around lights. If you memorize this little scripture here, you're gonna be yes.
Can you go through the difference between the acute closed and then the other one?
The acute will be sudden, painful, and it will have these key features immediately. The other one's more. Is someone messing with you outside?
It's just reflection.
Oh, okay. Do you want to lower the thing? Okay. Chronic is more progressive over time. It'll deteriorate your vision over time. So,
Is it painful, both of them?
this one, the acute is painful. The other one is just painless. It happens over time, over years. Okay. Sudden onset of severe eye pain, steamy cornea, hail dry. What is most common? B. All right. Good work. Helps you study. Okay. So, all right. Which one's essential for diagnosing glaucoma? B. Not C. You sure? All right. Awesome. And how do you measure that? What is the instrument called? Tonopen? Okay. Tonopen. The little puff of air in your eyeball. All right. So this patient has diabetes, sudden loss of vision, no pain. Blood and thunder. B. Okay. Awesome. Good work. How'd you all know that? Ooh. Cherry red spot, boxcar segmentation. A. See, this helps retain it. The more repetition you get. So. All right. Sudden monocular, not binocular. Loss of vision, no redness. What's happening?
D.
D? Yeah, let's see what happens. So final answer D. Hold on. Sorry. We're having some technical difficulties. Yeah. All right.
Central artery occlusion. But then it went forward.
Okay. Since I'm recording, I can't go backwards, but I'll fix it. I don't know. I forgot. Yeah, monocular loss of vision, sudden. I can't remember the choices, but
That weird word.
amaurosis fugax is the answer, basically. Okay. Any sudden loss of vision. Yeah. Yeah, but it'll be transient. If I proceeded with like a transient situation, it would be that. But okay, sorry about that. I screwed up. Risk factor for central retinal artery occlusion. D, all the above. Okay. Perfect. Sudden loss of vision, floaters. What are you going to use to help diagnose this? A. You want to go there? Okay, let's see what's that. Yeah, sure. Be confident. Say A. Damn it, that's my choice. All right, so good work. So vitreous hemorrhage, you'll look into the back of the eye. So autoimmune diseases, juvenile idiopathic arthritis, and sarcoidosis. A. Uveitis. Yes. You guys be uveitis experts by the time we get done today. We have to study it. All right, 70-year-old female. Ooh. Visual distortion, central vision loss. Drusen. B. You guys sure? Awesome. What gave it away? The Drusen? Drusen? All right, awesome. Yes, and old, yes. Over 50, you're done. All right, so. Yes. History of smoking, history of macular degeneration, central vision loss. D. All the above? Strong work. Flashes of light, floater. She's over 50. Or he's over 50, sorry. Shadow over visual field. Shadow over visual field. A. Okay, let's see what happens. Retinal detachment. Anything shadow or curtain immediately, it's painless. It's a retinal detachment, okay? All right, HIV, floaters, blurred vision, retinal necrosis. Which one is it? C? Okay, perfect. Yes. So, cytomegalovirus is seen in patients with HIV. Okay, yes.
Did you say retinal detachment is not painful? It is painful?
No, it's not painful.
Oh, okay.
No, it just happens. It's like, oh my God, I can't see. Yeah, it doesn't hurt. Okay, so if you see HIV, think CMV. Okay, you can put a tune to it. It's HIV, CMV. Okay. Okay, so which of the following is a risk factor for CMV retinitis? Hey. Oh. Yeah, so anything that's so if someone has HIV or AIDS, obviously their immune system's compromised. If you give them like corticosteroids or anything that's going to decrease their immune system, is also a risk factor. Okay, so poorly controlled diabetes or over 50, microaneurysms, neovascularization. B? Okay. Perfect. Diabetic retinopathy. Okay. What gave it away? It's diabetic. Okay. Man. That's another thing. Like, some of these vignettes are going to be a little long, but if you find a key word like diabetes, just go straight and look at the 4 choices.
Would it have to say diabetes in the vignette?
What's that?
Like it would have to say diabetes in the vignette.
Yeah. Or it could say poorly controlled blood glucose.
Yeah, but then you're gonna put like glaucoma, and that's gonna be the right answer. But we're
Yeah.
gonna pick something else.
Yeah. You just got to be careful. Be confident in your choices. All right. So, not a risk factor for diabetic retinopathy. Someone said duration. Okay, let's see. Smoking. While smoking is bad for your health, it's not a direct risk factor for diabetes. Okay. All right. So, patient with HIV presents cotton wool spots. Okay. Retinal hemorrhages and microvascular changes. B? Final answer? C? Oh, new answer? C. Okay. B or C? Let's go with it.
Ah,
C. Remember, cotton wool spots associated with certain diseases. Like HIV is one of them, right? Yeah. 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 Diabetic and HIV retinopathy have cotton wool spots. Okay. See, you're grouping stuff together. That's good. Okay. So where are we here? What are you going to use to diagnose HIV retinopathy? Fluorescein stain?
Okay, because all of the above better.
No. A? Okay, let's start. Don't worry about that. That's too advanced. I would have gone with A. Right? This is me trying to make things difficult, and I always fail. So don't worry about it. Honestly, it'd be in our world, PA world, would be fundoscopic exam. In ophthalmologist world, it'll be all this. Okay. 32-year-old woman. She has a chance. It's less than 50. So involuntary rhythmic eye movements. Ooh. Past few months. B.
Oh, you observed horizontal.
Okay, she's got horizontal movement. Wait, B? D? Okay, let's see what happens. B or D? Involuntary rhythmic eye movements is nystagmus, okay? It can be horizontal, vertical, or rotary, all right? Remember those little videos I put up there, those 10-second videos? Kind of review those, okay? So. All right, 28-year-old woman presents with sudden vision loss in her right eye and pain with eye movement, seeing flashes on light. Pupillary defect. B, optic neuritis. Okay, perfect. See, you guys are gonna be okay. See how it works? 60-year-old man presents with drooping of his right eyelid, double vision, difficulty moving his right eye. You'll find ptosis, dilated pupil, eye is depressed and out. What is most likely diagnosis? A, third nerve. Okay. Yeah, you got it. So associate these symptoms with the specific cranial nerve palsies. Okay. Yes.
sorry. What would it say if it was like cranial nerve 6? How would the eye be positioned if there was a problem?
Cranial nerve cyst is your abducens. So if that one's not working, if you can't abduct the eye, then it's going to be going the other way. Yeah, it's going to be medially, nasally. So, okay. 50-year-old man, horizontal double vision, difficulty moving his right eye outward. You find his right eye isn't able to abduct. What is most likely? Perfect. I just went over that. Did you look at this ahead of time? All right. So, for your woman, headaches, transient visual obscurations, and nausea. Do a fundoscopic exam, bilateral optic disc swelling. Was most diagnosis? C, papilledema. Okay. Perfect. So, if you associate certain signs and symptoms with specific disorders and presentation and patient history, you could work your way through this stuff, okay? And it's weeding out like outliers too. Like the 4 choices, you start looking at those, and you're like, this is obviously that's not it. This and oh crap, I'm down to 2. It could be either or, okay?